you know, Dr. Kraus, we've had some good presentations today. So,
all right. I'll try to keep up the...
Yeah, I think this will be a good one to end it on. And then after this particular program, we have a little time for some discussion to focus on tumors of the skin and also other topics discussed today. So please welcome Dr. Kraus on benign tumors of the skin.
Well, I'm sure you're all glad to see me, if for no other reason than I'm the last speaker, which means that after this one you can go on home on a Friday afternoon. So we'll try to make this informative and entertaining for you. Yes, okay. Obviously today is not Sunday, February 4th, but this is in preparation to another lecture and that I'll be giving at that time. In case you're not sure how to treat problems in the elderly, I brought along my over-the-hill voodoo doll. It tells you how to stay young. And wherever the problem is, you stick a pin in that area, and that wards off the over-the-hill afflictions. Some examples of problems you might encounter, you know, you can put the pin on allergies, wrinkles, graying hair, whatever, and that'll take care of the problem for you. You look like a pin cushion. That's exactly right. Let's see. What does that? Is it possible to lower the lights, or is that the way it's been all day? Do you need it for notes or something? Did you get a handout at all? Okay. Everything on the slide is in your handout. So, yeah. Can you focus that for me too, please? Can you focus that in the back? Other way. Let me. No, it'll sharpen up a little bit more. Okay, everybody okay? All right, this is the group of tumors I'd like to talk about. I have not included every possible tumor. Some of these lesions you will see on an everyday basis. Some of them you may not see at all. The benign tumor title may be a little bit misleading in that they may start off benign and may develop into a malignancy. They may start off benign and resemble a malignancy, or they may be benign throughout their life period. So let me talk about some common things first. We'll start off with common nevi, probably best known as moles. Just to let you know that moles have a sequential history throughout their life period. They start out as flat brown macules early on in life after about age 2. They then progress to become a little papular in young adulthood. And then in the older people, they tend to lose their color and become more sessile, soft, or pedunculated. Let me show you some examples. This is a flat macule on the skin. This is a so-called junctional nevus. Starts out early in life. Now, over time, as I mentioned, we then develop a papular component. This is referred to as a compound nevus. Histologically, the melanocytic cells are in both the epidermis and the dermis. And you start to get an elevation component to it, young adulthood. And it looks somewhat similar to this. Notice the nice uniform pigmentation. It doesn't have to be this dark. It could be much lighter than this. It could be a light shade of brown, medium shade of brown, dark brown. But it's very uniform in its pigmentation and appearance. And in the older age group, the pigment tends to be lost. They become softer. And some typical examples, as are seen here, this is a more sessile lesion. And here you have a more pedunculated, soft lesion. These are perfectly benign moles, what we call dermal nevi. And that's the progression pattern. Now, not every mole will go through that pattern, but that generally is the what you'll see. Someone will say, yeah, I had a dark mole when I was younger, and it's lightened up over a period of time. How do you treat common nevi? Well, if a patient comes to you and tells you that the mold that they have has been itching, bleeding, doing some change that's different from the normal pattern, they've been experiencing this over a period of time, say maybe a month or more, or if they develop a new lesion, they're already 35, 40 years of age, and all of a sudden they got what looks like a new mold, that's a good reason to go ahead and biopsy it. Just do an excision biopsy, remove the lesion, find out if there's any malignant change the lesion is undergoing. If the patient is only there because of a cosmetic reason, then it's perfectly reasonable to go ahead, take a scalpel braid, and shave it flat, even with the skin. Remember that you send in all specimens for pathology. Anything suspected of being a mold, a nevus, send it in even though you're just taking it off for cosmetic purposes. Congenital nevi is a category of nevi. These are moles that are present at birth. Now they do have a degree of significance. And you can have small congenital nevi, you can have medium, and you can have widespread or some very large congenital nevi. And this is what a typical nevus looks like at birth. Here you have something about 3.5 by 1.5 centimeters. You may have a uniform pigmentation, or you may have little darker areas within the area of the nevus. At the other extreme, you have a very large congenital nevus. Now, there's a small risk of malignant degeneration in the small congenital nevi, and that risk probably runs somewhere about 1, 2, or 3%. So if somebody has a small birthmark and they live to be 85, 90 years old, 1 to 3% of those patients will develop a malignancy within that particular small nevus. If it's a large congenital nevus like that one on the child that covers the entire body, the malignancy rate probably runs about 6, 8, or 10%. Here's an individual that had a congenital nevus and then later on in life developed this nodule, and it turned out to be a melanoma. So what are you going to do about congenital nevi? The large lesions are impossible to totally remove. You remove any suspicious lesions that develop. The moderate ones, which we defined as maybe palm-sized lesions, excise if possible. If you can't, then you watch closely. The small lesions, your options are to excise or to watch. If it's an area that's not cosmetically too important, it's certainly reasonable to go ahead and excise it and never worry about it. If it's in a cosmetic area, then you have to decide between the cosmesis of the mold or the excision, the scar that you're going to leave. In either case, you have to pay attention, look for changes. Nevus spillus is something you're unlikely to see. It's just kind of a unique little lesion, has a brown pigmented background with little darker lesions, darker macules within it. Just to show you a typical example, not likely to see too many of these. But here we have a brown background studded with these darker brown macules. If it's going to develop a malignancy, and these rarely do, they would develop them within the dark brown areas as opposed to the light area. So you could counsel the patient, look for changes within the dark brown spots. Blue nevus is another variant of a mold or a nevus. It just happens to be clinically blue. Its main significance to me is that people will confuse it with a melanoma. If you're not aware that such a thing exists, then you might think, well, it's very dark and it is worrisome. I'll show you some pictures. But just to be aware that there is such a thing as a nevus, and it has a blue color instead of the usual brown that you're used to looking at. They're either nodules or they're papules or sometimes even plaques. Rarely do they degenerate to malignancy. You don't really need to treat them, except if you're concerned about the diagnosis, you might want to go ahead and excise one. Here's one happens to be on a child, but if this is on an adult, especially any adult, you would certainly be concerned that this is a malignant melanoma. I'm sure if you stuck it out from this morning on, you saw some horrible looking melanomas, and maybe one of them looked something similar to that. But it actually has a blue cast to it as opposed to a brown. Here's one, an individual that has multiple blue nevi, at least 5 of them here on the scalp and on the forehead. A little closer picture. Again, getting that deep blue color. That gives you a tip-off that this is a variant of a nevus called a blue nevus, but it might be worthwhile biopsying one just to confirm that. This is an important topic, this thing called dysplastic nevi. They're also called atypical moles. And what they are, these are lesions that they look a little bit funny. By that I mean they're not the classic moles that are about pencil eraser size or less. They're not nice and round and oval. They're not uniformly pigmented, but they don't look real bad like the melanomas do. They're kind of somewhere in between. You look at them, you're not sure, is this abnormal? Is it not abnormal? Usually, when they're significant, there's a lot of them. These are the people that come in, they got what looks like moles everywhere, and they all look a little bit different, one from another. They tend to be on unusual areas, tend to be on covered areas. Scalp, buttocks, breast area, legs. Normally, a lot of nevi will be in sun-exposed areas. These tend to be in the non-sun exposed areas. And this is a typical example. You have a bunch of nevi, and they all, if you look one next to the other, they all look a little bit different. This is a close-up of a typical lesion. Has a little bit of brownish pigmentation in the center, a little red-brown around the edge. A little bit different than the normal nevi that you would normally see, some of the examples I gave before. And this is that fried egg appearance. This is where the area in the center is darker, a little bit elevated, and the surrounding area is a little bit lighter and flat. This is a typical dysplastic nevus. Why bother even bringing up the subject? And this is the reason. We have 2 groups of patients. We have those that have dysplastic nevi, but they have no family history of melanoma. And they have a slight increased risk of developing melanoma, maybe about 1, 2, or 3%. However, if you have a patient that has dysplastic nevi, and their family history includes 2 family members with melanoma, over their lifetime, they will develop a melanoma. Now, look at it this way. Dysplastic nevi are markers for those that are at risk of developing melanoma. Some of the actual dysplastic nevi will develop a melanoma, but more likely, you will get a melanoma that develops on the skin separate from the dysplastic nevus. Everybody following what I'm saying here? It's like a signpost. This area is at risk for melanoma. Okay, what are you going to do about, if you see one of these lesions, what are you going to do? First of all, it's not practical in these individuals to remove every nevus. Some of these people have 50, 100, 150 lesions, and it's really not practical. You look at the most dysplastic, the most abnormal looking lesion, maybe 1 or 2 of them, excise that, find out the degree of dysplasia, and then get a family history, and then follow these people over a lifetime. Okay, nevus sebaceous is another clinical lesion that you probably are not going to see, but I need to make you aware of it because it starts out as a benign lesion at birth and over time develops some warty changes to it. And then as you get older, you can develop some malignancy within the lesion itself. So this is one of these examples that I talked about, starting off benign and eventually may developing a malignancy within it. These are normally scalp or facial lesions, and there are 3 stages. At birth, you tend to see something that looks like this, a hairless yellow-orange plaque, a little bumpy on the surface. As the child gets a little bit older in young adulthood, you start to get this warty conglomeration over the top. And then, as the patient gets older, you start to get some changes in about 20% of these lesions. And what you wind up seeing, here is an elderly individual that has a basal cell carcinoma within it, and a more drastic example of the same thing. Here's someone that has multiple tumor-like lesions that has developed in a birthmark. Nevus sebaceous. Not likely to see too many of them, but just to be aware that if you happen to see one, a yellowish orange hairless plaque in the head and neck area, and you're seeing in an older patient, watch out for malignancy developing within that lesion. Treatment. The ideal treatment is, as the child reaches puberty and young adulthood, is to excise it. That's when you get them. But if you happen to see one later on in life, then you just go ahead and have that lesion excised at that point when you see it. This is a condition you will see, this sebaceous hyperplasia. This is the hypertrophy of the oil glands. These are the individuals that come in, they have a greasy, shiny face appearance to their skin. They will tell you that they'll take a little napkin and rub it across their forehead, and you'll see the little grease stain like a butter stain. Very oily skin, and it's a very common problem. Most of the time, it's a cosmetic problem. Occasionally, when there's only a few lesions, people may confuse them with basal cell carcinoma, and this is what they look like. They have this hyperplasia of the oil glands. They're little yellowish papules. Some of them will have a little central delve to them, a little central indentation. But here you can see multiple papules all over the face, and these are hypertrophied oil glands, what we call sebaceous hyperplasia. And a close-up of these lesions. Now, if I showed you just 1 or 2 of these, you might say, that looks an awful lot like the basal cell carcinoma that Dr. Day showed me this morning. And that's sometimes you run into that scenario. Usually you can tell by the yellowish quality in the central dell, and these things do not ulcerate. Usually a basal cell carcinoma over time will enlarge and ulcerate. And sometimes you can't tell, you need to do a biopsy. As far as treatment is concerned, probably if people want them treated, you just shave them down. Sometimes you can electrodesiccate them. Sometimes you can apply liquid nitrogen. To be honest with you, I've not been impressed with any treatments. Seborrheic keratosis, absolutely something you're going to see day in and day out. These are benign lesions. The biggest thing about seborrheic keratosis, first of all, there are a lot of them and they tend to be a cosmetic problem. But also, when they have a little bit atypical, when there are atypical features, then they can resemble melanomas. And sometimes you can actually get confused between seborrheic keratoses and melanomas. And I'll show you a few examples. The seborrheic keratosis does not become malignant. It does not convert into anything. You get more of them as you get older. They have a stuck-on appearance to them. It looks like somebody had taken the flat side of a little warty growth, stuck a little glue on, and then put it on the skin. They just look like you can take your fingernail and scrape them off. And people actually do that. They flick a little bit off, but it tends to regrow. They also have these little keratin-like pearls. It looks like little plugged pores on the surface. It actually looks like little blackheads, but it represents keratin. Now on the bottom here it says if you were to see somebody that didn't have a single seborrheic keratosis on them, and all of a sudden, within the last 2 or 3 months, they got hundreds of these things, then sometimes this is a signal that there's a malignancy triggering off this kind of growth. 20 years I haven't seen one of these, but you read about it, and there's a little bit of controversy. Let me just say this. If you have somebody 55, 60, 75 years old, they don't have a mark on them, and all of a sudden they get a tremendous number of unusual skin lesions, that probably represents a malignancy somewhere. And this is what it looks like. Typically, seborrheic keratosis, they tend to be multiple. Now you look at a back like this and you're not sure where you should go. You should carefully look at every lesion. You have to be careful. Sometimes you would look at this and say, well, those are all seborrheic keratosis, don't worry about it. Well, if you notice up here, this one doesn't look a lot like the rest of them. It may be just a darker version. But the point is, make sure you get a good look instead of just casually looking from about 5 feet away. Here are typical examples. Doesn't this just have that stuck-on appearance to it? Looks like you can take your fingernail, get under it, and peel it right off. So you have variations in sizes and shapes. They can be a light yellow, a little yellow-gray, various shades of brown, and even very dark to where they're almost black. And this is what I was referring to when I was talking about these little plugged keratin. This helps you quite a bit. When you see that, and you have that stuck-on appearance to it, that helps you make this diagnosis of seborrheic keratosis. And they can become very large. You can have these things just become tumor-like. But even on the surface, you still have these little keratin plugs. Now we'll get into ones that are a lot more difficult to tell. If you look at this, probably Dr. Day showed you some slides this morning, and he called this melanoma or lentigo maligna or some other malignancy. So this would be very difficult to tell. And on biopsy, this turned out to be seborrheic keratosis. How about this one? It's got a couple of shades of, it's got a light shade of brown, it's got skin color here, and it's got a brown-black appearance to it. Has those nice little keratin openings there. But could you really be sure? Could you really feel good about calling this seborrheic keratosis? You'd have to biopsy this one. What about this one? If this was filled in very nicely right in here and everything looked like this, you could say, oh yeah, seborrheic keratosis, no doubt. But you look at this piece missing and you're not sure whether it was just peeled off or what. Has a couple shades color to it. Another one of those, I'm not sure. The point I'm trying to make is when you think you're not sure, you got a couple choices. Refer to someone that is sure or biopsy it. It's probably not good to just be not sure and leave it alone. Okay, what can you do as far as, most of these are cosmetic in nature, so you go ahead and if the patient wants it treated, or sometimes these things itch and they want it treated, liquid nitrogen is clearly the treatment of choice. You can also take a blade, scalpel blade, and trim them off, and you can also electrodesiccate them. An easy way to do it is take an electrodesiccation, and cauterize the top, and then scrape them off with a curette. Yes, ma'am?
Did you say that these have a tendency to recur?
They have it, you mean once you treat them? No. Usually they'll recur if people pick at them.
Okay.
But if you treat them, they're usually treated.
Now, how would that be different than just picking at them than a shave excision?
You
Because you're just kind of scraping it off, are you not?
You're probably getting into the papillary dermis with your treatments, and these are all epithelial growths. With picking them off, you're probably not getting into the papillary dermis. It's probably the level at which you're taking it off. Keratoacanthomas, these are kind of an interesting lesion. Another one of those things that it fits into the category of benign lesion, but it resembles a malignant lesion, both clinically and histologically. Not so much histologically, but clinically it represents, it's a benign lesion that clinically can appear to be like a squamous cell carcinoma. And histologically, if you have a good dermatopathologist, they can clearly make this diagnosis. I have a caveat for you. If you're going to see a keratoacanthoma, which is a papulonodular lesion, comes up rapidly, in 2 to 3 weeks it's doubled in size, and it has a central keratin plug to it, and you decide, oh my God, this is rapidly growing, I got to do something, I'm going to biopsy it. You have to biopsy the whole lesion. You have to get underneath the lesion to send it to pathology. If the pathologist sees only a portion of the lesion, they will tell you keratoacanthoma suspected, cannot rule out squamous cell, and you're stuck. You're going to have to treat it as a squamous cell anyway. You might as well excise it from the beginning. Let me show you what these things look like clinically. This is over the clavicle of an older lady, rapidly growing, nodular lesion with a central keratin plug. The key things here are the rapid growth. You have a little papule. A lot of times they'll tell you, oh, I had a little pimple or something like that. People like to use the term pimple. I had a little pimple there, and now all of a sudden I scratched it a little bit, and it's doubled in size, and then it's doubled in size. So obviously, what you don't want to do is schedule them as a routine appointment 4 weeks down the line to get it taken care of, because then you're dealing with a lesion that's larger than when you first looked at it. So if you suspect a keratoacanthoma, treat it at that point. Some other examples. A nodule on the back of the hand. Again, notice that it's an erythematous nodule erupting out of the skin with this central keratin area. And by history, it's rapid growth. Could this be squamous cell carcinoma? Yes, it could. My personal opinion is treat them as squamous cell carcinoma. Do a nice little excision. You don't need a big margin, a couple millimeter border. Get the thing out, sew it up, and you're done with it. Another example on the forearm. Again, you're getting the same picture. These are very characteristic, especially with the history. But even then, you'll run into a few snags as far as somebody looking at it and calling it squamous cell carcinoma under the microscope is a possibility. My choice, complete excision. Some alternate choices that you don't need to get into unless you just decide that you want to be a keratoacanthoma expert. Pyogenic granulomas. These lesions, I don't know if anyone has ever heard the term proud flesh, but they tend to be triggered off by trauma, and you have this exuberant growth of blood vessels and tissue that has this red glistening surface and bleeds readily when you just nick it or something like that, or you traumatize it. It tends to bleed profusely. Initially, it tends to be triggered by some kind of a trauma. Let me show you what these things look like. Exuberant, proud flesh, glistening surface, easily bleeding. Here's one on the ear. Same sort of clinical appearance. Here's another one on the ear. Kind of resembles the same thing. This turned out to be a malignant melanoma. Not a whole lot different than this lesion I just showed you, is it? What's my point? The point is you expect that this is going to be a pyogenic granuloma. You go ahead and you biopsy it. You do not, under any circumstances, take this off, throw it in the trash, and burn the base. How do you treat it? If you shave it, get underneath it, just do a scoop shave, and by that I mean you're going down like this, underneath and coming back up, getting the entire lesion, cauterize the base, make sure that you're not leaving any abnormal tissue behind, and that'll heal up just fine. Obviously, you can excise these too with a margin. It's not necessary, but you can. Okay, another common clinical lesion called a senile hemangioma. I don't like that term senile. Of course, certainly to this audience, we don't want to use the term senile. Let's call them cherryangiomas or hemangiomas. But these are these little red vascular papules you see every single day on your patients. Every time you take somebody's shirt off in an older population, they have from one to many of these little red spots. These are little vascular malformations. They have no medical significance whatsoever. They're totally a cosmetic problem, if they are any problem at all. And this is what they look like. You've all seen them. Very easy to treat. You can go ahead. I usually mark them with a little ink pen or like a little Jensen Violet marker. Numb it up and then just go ahead and cauterize it. Sometimes I'll take a little blade, 15 blade, shave it even, just very superficially, cauterize the base. Dermatified bromas. These are common little firm, hard papules that tend to occur after trauma in women for some reason. Women tend to have at least one or two of these. And a lot of times it occurs on the legs. The question is, did it occur from shaving nicks? Not really sure. Sometimes people will tell you they had an insect bite and that's this developed. And when you look at them clinically, they're either a reddish or brownish, firm nodule. And that's the key. When you feel these things, they feel firm. The problem with them is they will sometimes convert from red to a brownish color. And as they go into brown, people get concerned that it has something to do with nevus cells or pigment change or melanoma or something. That's usually the biggest referral from a dermatified broma. Is this a melanoma? And there are some clinical features that you can do to distinguish these readily. Let me show you what they look like. Here you have a reddish nodule. When you palpate it, it's firm. Here you have a brownish papule, and when you palpate this, it's firm. When you go to squeeze it, it will retract under the skin instead of elevate. And this is what it looks like. This is the point I was making, and this is what it looks like. You go to squeeze that, and it retracts instead of elevates. The so-called dimple, D-I-M-P-L-E, dimple sign. But these are very easy diagnoses to make once you know what you're looking for. As far as treatment is concerned, some people use liquid nitrogen to flatten them out. I'm not really sure about that treatment. I usually tell people the following. If this lesion is bothering you and you really want it off, I will be happy to excise it, punch it out for you, and I will trade what you have for a scar. So a scar-like process for a scar, and let them decide. Sometimes they'll say, I'd rather have the scar and then it's flat so that when I shave over it, I don't nick it. And you leave it up to the patient. All right, we are in the home stretch. This is probably the last topic. Acrocordons. You're all used to seeing skin tags. Neck, armpits, groin, they seem to be everywhere. At one point in time, there was a question about whether they had any association with colon polyps. Current information would suggest that there's no association. To be honest with you, we really do not have a good explanation of why people develop skin tags. We do know it tends to, as you become a little bit overweight and more overweight, you tend to get more of them. But we don't have a really good explanation of why people get skin tags. They're little benign excrescences, little extra pieces of skin. They're soft. They're either flesh-colored or brownish. They're either pedunculated, by that I mean a narrow stalk, or they're sessile, a broader stalk. And you all know what they look like. and this individual happens to have multiple ones. Sometimes people want them off because their jewelry interferes, their clothing catches, they twist and become infarcted, or they just don't like them. They're easy to remove. My recommendation is that you numb these up. Some people want to take the scissors and go snip, snip, snip. I mean, it's not, if they're small, you can withstand the little snip. The problem you get into is you get a little bleeding point. So you go to numbers 2 and 3, and 1 is bleeding a little bit more, and 2 has started to bleed, and the third one hasn't quite started yet. And all of a sudden you're into the 5th one, and you got little blood patches everywhere. Don't get yourself into that situation. Go ahead and numb them up, take your scissors, snip them off at the base, cauterize where you just snipped off. Heals up fine. Okay. So in summary, we've gone over a series of benign lesions, some of them that are always benign, some of them that simulate a malignancy, and some of them that actually have the potential of developing a malignancy at a later point in time. You've made it. Congratulations.
One single question.
Sure, sir.
Please comment, doctor, on actinic dermatosis and malignancy.
I'm sorry, sir.
Actinic dermatosis. Solar.
Like actinic keratosis?
Yes.
Oh, and your question, you
My
mean?
question is, do they lead to malignancy?
Oh, okay. The question is, do actinic keratosis lead to malignancy? The short answer is yes. The long extended version is that very small numbers of these would go on to be a malignancy. So say you had 100 of these lesions. Maybe 1 or 2 of them would slowly progress on to be a squamous cell carcinoma. So how are you going to determine which ones will do that? The larger ones, the more indurated ones. If you have a flat little roughened area and it's a 5 millimeter lesion, it's been there for several years and patients not really too worried about it, I don't believe that's the lesion that's going to be the squamous cell carcinoma. When you look at the lesion, it's already a 1 centimeter plaque, it's got irregular borders, it's thickening up. That's the one that will become the squamous cell carcinoma over time, and those are the ones I recommend to have treated. Other questions?